Okay, so a very good evening, everyone. Just give me a minute. I'll be starting the session in a minute. Okay, so just 1 or 2 minutes, some technical glitch. I'm very sorry, guys. Just give me few minutes. Okay, right. So I welcome you all to this PYQ series in general medicine. So by now, you people have almost done with your entire preparation. So in this last hours, what is very much required for you is the previous year question discussion. So as the general medicine is being like very vast, so today I will take up the discussion of 3 or 4 chapters. I will take up the PYQ discussion of the emergency medicine, infectious diseases, cardiology, and as well as nephrology. So these are the 4 topics which I'll be discussing today. That is previous year questions of these 4 topics. And let us start the session with a positive note, right? Definitely all of you are working hard to get this very important, that is success. So what is the secret of success which is being said by APJ Abdul Kalam is like taking the right decisions. Now very important is how do you make right decisions? That is by gaining the experience. Now how do you gain experience? That is by taking the wrong decisions. So this is the very important part of our career, right? So achieving the success is nothing but just doing the or taking the right decisions. That is very important part, like how you can achieve the success. And very important point, I do understand that in the later part of your preparation you will be under a lot of stress. So one important thing you should remember is that if you can't handle stress, you won't manage success also. If you are able to handle the stress, then only you will be able to manage the success. So keep that very important point in your mind, and always set your goals high and do not stop till you get there. Okay, set your goals very high and just be under a motive that I will success in my life definitely. It may not be immediately, but definitely I will achieve that particular success. So with this particular motive, let us start with the discussion. So now let me just tell you what is going on Unacademy. So Unacademy has come up with the important batch courses that is mainly for the FMGE students. Okay, that is the FMGE Mastery Batch, right? And this is a 5 months program wherein this batch course is mainly targeting the students who are appearing for the June FMGE exam. Okay, and this batch course, it is starting from February 6th, and the entire subscription has been put up with a very minimal price. The price is just only 17,213 rupees, and if you use my code MED10, you will be getting 10% additional discount also. Okay, and the other important batch course, this particular batch course is mainly for the students who are appearing for NEET PG 2023 March 5th. That is the final booster batch. This particular batch course have started on February 1st, and this is just only 1 month duration, and the cost of this batch course is 3,999 rupees, and if you use my code, that is MED10, you can get 10% additional discount as well. And mainly for the students who are like MBBS Prof 1, right? So a separate batch course which has been started, like answer writing the test for MBBS Prof 1, and every day like 5 questions will be taught for you. Okay, and for enrolling this batch course, you can use my code, that is MED10. So these are the 3 important batch courses which are starting on Unacademy, right? So in the today's topic, the discussions will be on the emergency medicine, then the infectious diseases, then the cardiology, and as well as the nephrology. So these are the topics for today, right? And this particular session will be around 2.5 hours, and I will try to discuss nearly around 100 questions. I'll try to discuss nearly around 100 questions in this 2 to 2.5 hours. Okay, right. Now the first question is, yeah, a 76-year-old man develops an acute kidney injury 2 days after an elective knee replacement. His past medical history includes mild chronic obstructive disease, right, and hypertension. These are the 2 important problems in the past history. He is hypotensive. Blood pressure is 80/50, oliguric, and urea levels are 50.4 milligrams per deciliter. Normal urea levels are 15 to 40. And creatinine is also elevated, that is 1.87 milligrams per deciliter. Potassium is 5.1, and the bicarbonate levels, they are normal. He has received 30 ml per kg of intravenous fluid over the past 2 hours. Which will be the most efficacious measure to improve his renal outcome? Yes, please answer this question. Yeah, and the PDF of this particular session will be sent to my Telegram channel, right? My Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. So immediately after the class, I will send you the PDF with annotations, which will be helpful for your final revision. Okay, right. So what do you think is the quick answer? Intravenous furosemide infusion. Okay, now you see the blood pressure of the individual is 80/50, and if you give intravenous furosemide, that will further cause the drop in the blood pressure. So intravenous furosemide infusion is no way the best answer in this particular question. Okay, right. Then what would be the other alternative? Okay, good. Now let me just take up all the points. Now this particular patient has the multi-organ dysfunction like picture following arthroplasty. See, this particular patient has undergone elective knee replacement. Okay, that is nothing but your some sort of the knee replacement or arthroplasty. Now, what exactly is the pathology for the development of this hypotension and acute kidney injury is not known. Why am I telling multi-organ dysfunction? Because acute kidney injury is there where creatinine is elevated and blood pressure also drop it down. That is 80/50. Okay. Now, what exactly is the pathology is not understood, but it may involve an inflammatory response to the cement. Okay, so we use this POP, right, plaster of Paris. So this could be, I'm not telling this exactly, this could be the inflammatory response to this particular cement. Now, like what all you are seeing here, the glomerular filtration rate is slightly reduced. What exactly is reduced, we did not calculate. As the glomerular filtration falls, there may also be an accumulation of antihypertensive drug causing a cycle of organ dysfunction, because this particular patient is on the ACE inhibitor. Now, once the individual has developed renal failure, there will be accumulation of this antihypertensive drug, and that could also be contributing to the hypotension. We don't know what exactly is the reason for hypotension. Now, already you have given how much, 30 ml of the fluid you have given, right? Already you have given 30 ml per kg of the fluid in a short period of time, right? For how many days you have given? For since past 2 hours you are giving, like let us assume like 70 kg person. So 70 multiplied by 30, right? That means you have given almost 2 liters in the past 2 hours. In spite of giving 2 liters, the blood pressure has not improved still. The blood pressure has not improved still. So further fluid challenge will be of no use. And you take renal replacement therapy. Renal replacement therapy is not required at this stage and will not improve the renal outcome. When we do renal replacement therapy, when the individual is refractory to medical management in case of acute kidney injury, then we do renal replacement therapy, right? But that particular situation is not there. Now, what is that we require is to improve the blood pressure of the patient, right? For which you need to give a noradrenaline infusion. Noradrenaline infusion is best option as it will improve the mean arterial pressure, right? This will improve the mean arterial pressure, and it will also improve the glomerular filtration rate. And how it will improve the glomerular filtration rate? By causing vasoconstriction of the efferent arteriole. By causing vasoconstriction of efferent arteriole, even your noradrenaline can improve the GFR also. So the correct answer here is the intravenous noradrenaline infusion. The answer is D. So I have also said you how to rule out the other options. First option is ruled out because it is not end organ, it is not your end stage renal failure, or it is not like refractory to medical management. So first option ruled out. Second option, because already you have given 30 ml per kg for 2 hours, still there is no improvement in the blood pressure. So further supplementing fluids will be of no use. Already you have given 2 liters if the patient is around 70 kg. And the blood pressure is already less, and supplementing furosemide will further cause the hypotension. So furosemide should not be given. So what we give here is noradrenaline. That will improve the GFR and that will improve the renal perfusion. Okay, right. If you have any doubt in this question, you can text me. Okay, right. Now the next question. So the first questions, like whatever I am discussing now, is from the emergency medicine. Okay, the first 20 or 25 questions will be from the topic of the emergency medicine, right? And followed by that cardiology, nephrology, and then infectious diseases. So these 4 topics PYQs I'll be discussing now. Which of the following is a red flag symptom in a person presenting with a headache associated with taking codeine tablets for a week, gradual onset, improved by lying down, right arm weakness? The question is about red flag sign. Very good, excellent, super. I'm very happy about that. See, when you are using the word red flag sign, that means it is a dangerous sign in a patient with having the headache. Now, what you have to remember is, if there is presence of a focal neurological deficit, which is nothing but your right arm weakness, that tells you that there is some intracranial lesion. Right, that tells you that the individual is having some intracranial lesion. Okay, so now what are all the red flag signs in a patient with headache? That includes, number 1, the headache. It should be not gradual in onset. If the headache, if it is like sudden onset, then it is a red flag sign. Then if there is a constitutional symptoms along with headache, that means like along with headache there is rash, like Neisseria meningitis, that would be a red flag sign. Then signs of raised intracranial pressure, that is headache improved by lying down. No, if the headache increases on lying down, that is a sign of raised intracranial pressure, and that is a red flag sign. Okay, so these are the red flag signs. Number one, sudden in onset, headache along with that rash, signs of raised intracranial pressure like headache worsening on lying down, and if the age of the person, if it is like more than 60, having severe headache, that is also a red flag sign. So here the correct answer is the right arm weakness. Okay, right. So that was about like red flag signs in the headache. Next, you see the next question. Which one of the following statement best describes good practice when using sedation and analgesia in intensive care? Yes, any one of you please. Which of the following statements best describes good practice when using sedation and analgesia in intensive care? A Richmond agitation and sedation score, that is RAS score of 0, suggests sedation is optimal. Etomidate is most stable sedative and should be used as infusion in patients who are very unstable. Patient should be deeply sedated to reduce the risk of delirium. Sedation should not be stopped abruptly as there is an unacceptable risk of self-extubation. Right, now let me tell you what exactly is the correct answer, and I'll try to give the explanation of the other options as well. So the correct answer here is the RASS score of 0 suggests a sedation which is being optimal. Right, now at this point what about this particular other options? I will tell the other options, then we will go to the first option. You take this etomidate. What exactly is your etomidate? It is an anesthetic agent. There are many sedative agents that are used safely. Etomidate is not used by infusion. Why? Because this etomidate will cause adrenocortical suppression. Right, this etomidate will cause adrenocortical suppression. So that is the reason why etomidate is not used as an infusion. That is very, very important. Don't use etomidate. Next, now patient should be deeply sedated to reduce the risk of delirium. Please remember, deep sedation does not reduce the incidence of delirium. In fact, it probably increases the risk of delirium. Please remember, the deep sedation will increase the risk of delirium. It will not decrease the risk of delirium. Okay. Next, fourth option. Now, sedation should not be stopped abruptly. Please remember, what we do in the ICU care is daily sedation breaks are used. We abruptly stop the sedation. Daily sedation breaks are used safely in many intensive care units. Okay. So this is also a wrong statement. Then what is the correct statement? Patient should ideally be calm, able to follow the commands, and tolerate the endotracheal intubation. If that particular RAS score is 0, that means patient is calm, able to follow commands, able to tolerate the endotracheal intubation. That suggests the sedation is being optimal. So the answer here is the first option, right? Why not the second option? Etomidate will cause adrenocortical suppression on infusion, right? And deep sedation will increase the risk of delirium. And sedation breaks are done every day in every ICU care. Okay, right. So the answer is A here. And moving to the next question. If you have any doubts, Roman, please do MCQs on heart failure. Yes, Roman, just wait for a minute. Once we come to the topic of cardiology, I will discuss the MCQs on heart failure as well. Okay, right. Okay, now, which one of the following findings suggest that ongoing intensive care treatment still has a realistic chance of good neurological outcome following a cardiac arrest? CT showing preserved gray-white differentiation, absent corneal reflex at 72 hours after return of spontaneous circulation, absent motor response to painful stimulus 72 hours after return of spontaneous circulation, myoclonic jerking within first 24 hours after return of spontaneous circulation. So the question is, which of the following findings suggests that ongoing intensive care treatment still has realistic chance of good neurological outcome? Good neurological outcome. Okay. So please remember, a CT brain showing a preserved gray-white differentiation, that is a good neurological outcome sign. Now, what is this preserved gray-white differentiation? Let me show you this. Okay. Now, this is what is your normal gray-white differentiation. So you can see here the white color line and as well as the gray color appearance. That is what is your gray-white differentiation. So if there is normal gray-white differentiation, or if this gray-white differentiation is preserved, that is a realistic chance of a good neurological outcome. For suppose, now you see here the gray-white differentiation is being lost. If it is being lost, that tells the chance of the neurological outcome is poor. Okay, so the answer here is the first option. If you take the remaining, all other signs are strongly predictive of the poor neurological outcome. So all these tells you that the individual has a poor neurological outcome. So the answer in this question is the first option, right? Where there is, if the individual is having a normal gray-white differentiation, the neurological outcome will be good. Now we'll move on to the next question. Okay, a 37-year-old previously healthy man is brought into the emergency department by ambulance, having stopped the car he was driving. Okay, so he was driving the car and he stopped, and that particular car was being seen by some person, informed to the emergency. So emergency department. So that particular person was brought to the emergency department. When the paramedics arrived, he was conscious but appeared confused. This progressed over the following 30 minutes to aphasia. That means from a state of confusion, he has gone into a state of aphasia, loss of speech. And there is development of bilateral upper and lower limb weakness with bilateral cranial nerve palsy. CT scan head on arrival is reported to be normal. Which investigation is most likely to reveal the underlying pathology? Okay, now if you take the sequence here, the individual was in a state of confusion. Within 30 minutes, he has developed aphasia, then immediately developed bilateral upper and lower limb weakness, bilateral cranial nerve palsy. CT scan on arrival appeared normal. Okay, so the correct answer, if you observe here, okay, the correct answer is the CT angiogram of the circle of Willis. Now, why not the other options? And then we will move on to the first option, why answer A is correct. So you take CT of the cervical spine. Now, if you are suspecting that if there is any C-spine fracture, what the patient should have? The patient should have the quadriplegia. But our patient, along with quadriplegia, is also having the the manifestations related to the involvement of brain. How can you say that the individual has appeared confused? Then second important point, has developed aphasia. That tells that there is involvement of cerebral cortex. So CT scan of the cervical spine is of no use. Then ECG, in what way it will be useful in a patient with CNS manifestations? It can tell you if there is any cardiac involvement, but in our patient, like, we are suspecting that there is cerebral cortex involvement. So ECG will not be useful, and even ESR will be also of no use. So the differential diagnosis here is a cerebrovascular accident. Okay, so this particular patient might have developed a cerebrovascular accident, or the individual might have developed a seizure disorder, or the patient might have developed progressive encephalomyelitis. So if you take the speed of onset, confused, aphasia, bilateral neurological deficit, it is likely that the patient had the vascular event. It is likely that the patient had the vascular event. And if you want to make out the vascular event, The CT angiogram of the circle of Willis has the highest diagnostic yield in the acute setting. Okay, has the highest diagnostic yield in the acute setting. So the answer here is the A. Right, very good, Dark Knight. Yes. So if the individual had this particular aphasia, definitely it is middle cerebral artery involvement, right? And that too, middle, which side middle cerebral artery involvement it should be? It should be left MCA. Left MCA. Right. Yes, Gokul Krishnan. Yes. Why not embolism? It would have been your cardioembolic stroke also. But by doing ECG, will you be able to diagnose that cardioembolic stroke? No. You will not be able to make out that the individual had a cardioembolic stroke by doing ECG. It would definitely be embolism, but ECG will not help you to tell you that it is a cardioembolic stroke. I am telling you, right? It's a vascular event, definitely. Either it would be hemorrhage, or it would be thrombosis, or it would be your embolism, right? And how to make out that particular vascular event among the options given to you? That is CT angiogram of circle of Willis. Yes, Gokul Krishnan, did you understand this point? Right. Next. Okay. Then, having said this, we'll move on to the next question. Right. A 60-year-old woman with a previous head injury is admitted with collapse. Right. Admitted with collapse. Taken from the history alone, which one feature may point to a diagnosis of syncope rather than seizure? Amnesia, cyanosis, olfactory aura, rapid recovery back to baseline state, tongue biting. Very good, Malla Reddy. So it is rapid recovery back to baseline state. That tells you it is suggestive of syncopal attack, but not the seizure. But not the seizure. Okay, right. Now, differentiation between seizure and syncope is very, very important point of discussion. Let me just give you a table of differentiation between the seizure and as well as syncopal attack. You take the seizure and syncope time of onset. Syncopal attack usually daytime, seizure it can occur day or night at any time. Position, if you see, syncopal attack it always occur in upright position, whereas seizure it occur in any position, either upright or even in supine position also. And syncopal attack it is usually gradual, but seizures they are like very sudden in onset. And what about aura? Right, aura can be present in both of them. And what about the color of the lips? In case of syncopal attack, the lips they become pale. And autonomic features they are very common in case of the syncopal attack. And what is the duration of that particular attack? In case of seizure it is around 30 to 60 seconds, but there will be a quick recovery or short episode in case of the syncopal attack. And incontinence it is very common in case of seizures, but not in case of the syncopal attack. In syncopal attack it is very rare to have the incontinence. And even the postictal confusion, postictal confusion also can occur in seizure, but it is very rare in case of syncopal attack, right? And what about the injury? That is a tongue biting. Tongue biting is very common in seizure, but very rare in case of the syncopal attack. And what about automatisms? Automatisms are also very common in case of seizures, and that too complex partial seizures, but never in case of syncopal attack. And when you do EEG, you will have an abnormal EEG in seizures, but it will be normal in case of syncopal attack. And what will be the duration of unconsciousness? The duration of unconsciousness, it will be just only for few seconds in case of syncopal attack. But whereas in seizures, the duration of consciousness will be minutes. Okay, so this is about the differences between seizure and as well as the syncopal attack, right? Next, having said this, and yes, Christy James, most common reason of the syncopal attack. See, there are actually many reasons for the syncopal attack. Like you take the embolic, like for example, you take the neurological incident, that is your embolic strokes. Embolic strokes, before the development of the ischemic stroke, the individual can have TIA, transient ischemic attack. They can present with syncopal attack, right? Or your hypoglycemic episodes, they can present with syncopal attacks. Or autonomic neuropathy, they can present with the syncopal attacks. Hypovolemic shock, they can also present with the syncopal attacks. But if you ask me the most common reason, that would be the hypovolemic shock. That would be the most common reason for your syncopal episodes. Okay, right. Now, having said this, we'll move on to the next question. Which one of the following statements regarding daily management in intensive care unit is most accurate? Blood glucose levels should be maintained in the range of 72 to 108 in ICU. Proton pump inhibitors and the histamine H2 reduces the incidence of gastrointestinal bleeding. Hemoglobin should be kept about 10 grams per liter in the ICU. Unfractionated heparin is more effective than low molecular weight heparin at preventing pulmonary embolism. So what do you think is the correct statement? Okay, so now let me just quickly tell you here, right? So yes, so those students who have answered A is correct, right? I'm sorry, not A, I'm very sorry. Those students who have answered, no, I did not get the correct answer from any one of you. Very good, Gokul has answered now. The answer is B. Now, let me just tell you all the options. In a patient who is in ICU, what is the recommended blood glucose levels? The recommended blood glucose levels are around 108 to 180 milligrams per deciliter. This is the recommended blood glucose levels in a patient who is there in ICU. Okay, so first option is ruled out. Then now hemoglobin level should be kept about 10 grams per deciliter. No, what is the threshold? Threshold is 7 grams per deciliter. Okay, 7 grams per liter. And if it is less than 7 grams per liter, then blood transfusion should be given. So it is not your 10, it is 7. More than 7, you have to keep it maintained. Less than 7, you need to give blood transfusion. Then you take between unfractionated heparin and low molecular weight heparin, which is best. It is always low molecular weight heparin which is best than compared to that of unfractionated heparin in preventing the development of the pulmonary embolism. So your option D is wrong. Then what is the correct answer here? Proton pump inhibitors and H2 antagonists, they reduce the incidence of gastrointestinal bleeding, right? That is correct statement, but they may increase the risk of nosocomial infections. They may increase the risk of nosocomial infections. And why is that we give in patients with ICU? Because of the development of stress ulcers, right? And what are these particular stress ulcers? These stress ulcers are nothing but your Cushing ulcers. So in order to prevent them, we give proton pump inhibitors and as well as the H2 receptor blockers. That is a correct statement. Okay, right. Now we'll move on to the next question. Okay, a 46-year-old, this is very important, and let me see how many of you can answer this. A 46-year-old previously healthy man is in intensive care following following an influenza pneumonia with ARDS. He was on veno-venous ECMO for 10 days and is now receiving ventilatory support via tracheostomy. It is noted today that he has bilateral weakness of his arms and legs. This has become apparent since his sedation has been lightened. On examination, he has marked proximal muscle weakness. Tone and sensation appear to be normal. Okay, tone and sensation appear to be normal. Deep tendon reflexes are present but reduced. Plantars are downgoing. That means normal plantars. Cranial nerves are intact and patient is alert, oriented and obeys commands. Which of the following is the most likely diagnosis in this patient? No. No, it is not Guillain-Barré syndrome. It is not Guillain-Barré syndrome. See, in patients with Guillain-Barré syndrome, they will not have reduced deep tendon reflexes. The deep tendon reflexes are completely absent. The deep tendon reflexes, they are completely absent in patients with the Guillain-Barré syndrome. And it is in case of Guillain-Barré syndrome, it is not just only proximal muscle involvement. It is both the proximal and as well as the distal muscles. Both are affected in patients with the Guillain-Barré syndrome. But if you see our question, it is only the patient is having marked proximal muscle weakness. That is what is not seen in patients with the Guillain-Barré syndrome. Okay, and even you take the cranial nerves in patients with Guillain-Barré syndrome, the seventh cranial nerve, bilateral seventh cranial nerve palsy will be there, right? But if you see here, what he has mentioned that the cranial nerves are normal. The cranial nerves, if you see here, the cranial nerves are intact. So all these points are not in favor of your Guillain-Barré syndrome at all. So Guillain-Barré syndrome is completely ruled out. Okay. Then what about the other options? You take a lesion of the brainstem. See, if there is lesion in the brainstem, you take either midbrain, right, or you take pons, or you take medulla oblongata. See, in midbrain you have cranial nerves 3 and 4, right, and even you have the 5 which is starting between midbrain and as well as pons. You don't have the 5th cranial. So cranial nerve involvement is not there in this patient, so that will rule out the brainstem involvement, right? Whereas pons, if you take, you have 6, 7, 8 cranial nerves, whereas in medulla oblongata you have the last cranial nerves 9, 10, 11, 12. So there is no cranial nerve involvement in this patient, so how can you take it as the brainstem involvement? So it is not brainstem lesion. Now to consider rhabdomyolysis. See, when can you tell that the patient had rhabdomyolysis is at least there should be a history of crush injury, or there should be an elevated creatinine kinase levels. Rhabdomyolysis should be considered if there is raised creatinine kinase, okay, and which is not mentioned in our patient. So rhabdomyolysis is also ruled out. Then what is the only best answer here? That is critical illness myopathy. Okay, critical illness myopathy. See, there is no feature of the central nervous system lesion, so brainstem involvement is gone. The patient is having normal sensation and reflexes are reduced. So peripheral neuropathy. What is your Guillain-Barré syndrome? It is a disorder of the demyelination of peripheral nerves. Okay, right. I have ruled out Guillain-Barré syndrome by telling you all these points. Okay, so the answer here is the critical illness myopathy. What is that? It is a critical illness myopathy, right? Next, now these patients with critical illness myopathy, they generally have good prognosis, and patients recover from the primary pathology. Once the primary pathology is recovered, even the patient of critical illness myopathy also will be recovered. So the correct answer here is the critical illness myopathy, right? Okay, now what is the question? Yes, dark night, Guillain-Barré syndrome versus the transverse myelitis. Okay, a very good question by the dark night. See, Guillain-Barré syndrome, like it is completely the flaccid paralysis. That means what does that you have dark night? You have only LMN features, right? And you have ascending paralysis. You have ascending paralysis, okay, right? And that means at one point of time, upper limb, then trunk muscles, then lower limb muscles, then finally respiratory muscle involvement will be there in Guillain-Barré syndrome. Whereas dark night, if you see in transverse myelitis, at the site of lesion, you have LMN involvement or LMN features. Below the site of lesion, you have upper motor neuron features. Okay. So this is a very, very important differentiating point. In case of Guillain-Barré syndrome, you will never have the upper motor neuron features. In case of Guillain-Barré syndrome, it is always the LMN features. That is a very important point of difference between these two. And in patients with transverse myelitis, you don't have that particular pattern of ascending involvement, right? Just below the lesion, everything is being completely gone. Just below the lesion, wherever might be the site of lesion in the spinal cord, in case of transverse myelitis. But that ascending pattern is not being followed in case of transverse myelitis, okay? And the next important thing is the history. Guillain-Barré syndrome usually occurs with a pre-existing gastrointestinal or respiratory tract infection, right? There should be past 1 to 4 weeks of your gastrointestinal or respiratory tract infection in case of Guillain-Barré syndrome. But in case of transverse myelitis, you don't have that past gastrointestinal or respiratory tract infection, okay? Yes, dark night, is that clear for you, dark night? Okay, right. Having said this, we'll move on to the next question now. Okay, so the question is, a 45-year-old man arrives in the medical receiving unit complaining of the headache, blurred vision, nausea and vomiting. His blood pressure is 256 by 138 millimeters of mercury, and because of that high blood pressure, he is having headache, blurred vision and nausea and vomiting. But CT scan is appeared normal. Which of the following statement is true? Chest pain in this context is likely to be anxiety related. In this context, nausea and vomiting is unlikely to represent the raised intracranial pressure. Shortness of breath in this context may be the result of the pulmonary edema. The blood pressure should be reduced rapidly, aiming for a 50% reduction in MAP, mean arterial pressure, in the first hour. The use of cannabis is a recognized precipitant. Okay, what do you think is the correct statement? Right. Now, let me tell you what exactly is the correct statement and let me rule out the other options as well. Now, presence of shortness of breath in this context may be the result of the pulmonary edema. Now, 256 by 138, what do you think is this particular patient having? This patient is having the hypertensive crisis. This patient is having hypertensive crisis. Now, this hypertensive crisis, we classify that into the hypertensive emergency or the hypertensive urgency. If you take a hypertensive emergency, what does that tells you? There is end organ damage. Hypertensive urgency, there is no end organ damage. Now, what about the other options? Right? What about the other options? You take, okay, leave about chest pain. Chest pain in this context is likely to be anxiety related? No. If at all, if the patient have developed chest pain in this particular context, that would be secondary to a myocardial infarction. It is not related to anxiety in case of the hypertensive emergency. Then what about the second option? In this context, nausea and vomiting is unlikely to represent raised intracranial pressure is a wrong statement. Nausea and vomiting may be a sign of raised intracranial pressure. Okay, it is a sign. It unlikely is a incorrect statement. Now, why there is shortness of breath in this patient? Shortness of breath may indicate the pulmonary edema. Why there is development of pulmonary edema? See, this particular accelerated hypertension has caused the individual into hypertensive heart failure, right? Hypertensive heart failure. And once there is hypertensive heart failure, the individual will develop pulmonary edema causing dyspnea. So the third C is a correct statement. What about the fourth option? Like the blood pressure should be reduced rapidly. See, like how much you have to reduce in the first hour. In the first hour, you have to reduce 10 to 20% of mean arterial pressure. But there are exceptions in two conditions. Like for example, you take aortic dissection or you take in case of acute stroke. In aortic dissection, you can do abrupt or rapid reduction in the blood pressure. Except for this aortic dissection, in all the other conditions, in first hour, you have to reduce 10 to 20% of mean arterial pressure, and within 24 hours, how much you have to reduce? Within 24 hours, 25% should be reduced, within not more than 25%. Okay, mean arterial pressure should be reduced up to 25% the baseline value, not more than 25%. This is very, very important. Now, what about this cannabis story? See, what would be the precipitants for the development of hypertensive crisis is the hyperadrenergic state. Like what would be the precipitants that can cause this hypertensive crisis is cocaine will cause hypertensive crisis. Amphetamines can cause hypertensive crisis. Monoamino oxidase inhibitors can cause hypertensive crisis, but not your cannabis, but not in your cannabis. Okay, so that is the reason why even your option E is also ruled out and option D is also ruled out. The shortness of breath in this context may be result of pulmonary edema is a correct statement. Okay, right. Yeah. Now, yes, Gokul Krishnan, see, the difference is when we are using the word hypertensive crisis, that means the systolic blood pressure is like more than 180 and diastolic blood pressure is more than 120, right? Now, these two, we classify that into hypertensive emergency and hypertensive urgency depending upon end organ damage. In case of hypertensive emergency, you have end organ damage, whereas in hypertensive urgency, there is no end organ damage. That is what is the difference between your hypertensive crisis and as well as the hypertensive emergency. Now, what is the drug of choice for hypertensive urgency? Arunan, see, in case of hypertensive urgency, we don't give intravenous antihypertensive agents. In case of hypertensive urgency, we give the oral antihypertensives. That will suffice. and the preferred drug that you can give is labetalol. The preferred drug that you can give is labetalol. Okay. Yes, Arunan YT, is that okay for you? Right. Then Udhara, what are the indications for CT head? Now, if you take in this patient, why did I take the CT is because the blood pressure of the individual is like in a state of the hypertensive crisis and the patient is having headache, right? And I want to know whether the patient has developed hypertensive hemorrhage. That is the reason why I want to do CT scan in this particular patient, right? And what are the other indications for CT scan? If the patient had developed any particular focal neurological deficit, that is an indication for CT scan. And if the patient is having the symptoms suggestive of meningitis, like headache, photophobia, neck stiffness is there, then you need to do CT scan to rule out the intracranial pressure. And if the patient is presenting with recurrent seizures, then also we need to do CT scan to rule out if there is any presence of intracranial space occupying lesions, right? Or if the patient is having idiopathic intracranial hypertension, then also that is also an indication for your CT scan. Or if the patient is presenting to you with headache, like severe headache which he has never felt throughout the life, then also you need to do CT scan to rule out subarachnoid hemorrhage. And you also need to do CT scan secondary to any head injury. These are all the indications for CT scan. Okay, right. Who was that asking me? Was Udhara. Yes, Udhara, is that clear? Is your doubt cleared for you? Shalini, clonidine, yes, you can give clonidine, but the only problem with the clonidine is it can cause abrupt fall in the blood pressure. You need to take care of that abrupt fall, because if you are causing abrupt fall in blood pressure, you can precipitate the ischemia. So that is the reason why we don't give clonidine as a first line agent for hypertensive urgency, but the preferred drug is labetalol. Okay. Yes, Arunan. Hypertensive crisis, nicardipine, and pregnancy, labetalol. Yes, you can give labetalol, and even nicardipine is also a preferred drug. You can give that. Okay. And yes, Asadullah, the differences between AIDP and as well as CIDP, right? Just give me 5 minutes or a few minutes, Asadullah. We have a question on CIDP, chronic inflammatory demyelinating polyneuropathy. So I will just discuss the CIDP, a separate question itself. Okay. Right. Yes, Varun, you're right. Now, once we are done with this, we'll move on to the next question. Okay. A 25-year-old man presents to the emergency department with 4-day history of chest pain and mild shortness of breath. He feels that the pain is worse on lying flat and coughing and deep breathing. So it is relieved by sitting forward and has improved with ibuprofen. This point is very, very important. Improved with ibuprofen. He has no significant past medical history but was recently unwell with a non-specific viral infection. ECG showed widespread saddle ST segment elevation. What is the most likely cause of the chest pain in this patient? Right. Very good. So the correct answer here is the pericarditis. So what are the points in favor of pericarditis? The points in favor of pericarditis is that one is pain which is worse on lying flat, coughing and deep breathing, and relieved in sitting forward. That is another point in favor of pericarditis. And pericarditis is what? It's an inflammatory pathology which can be reduced by anti-inflammatory drug. Your ibuprofen is what? It's a non-steroidal anti-inflammatory drug. That is another point in favor of pericarditis. And what is the cause of pericarditis here is the patient had a past history of non-specific viral infection. So what are those viral infections which are very common is the Coxsackie A and B virus and the ecovirus. These are the two important viruses which can cause this pericarditis. And another very important point in favor of pericarditis is widespread saddle ST segment elevation. But what is the only exception in this? Like AVR, you will have ST segment depression, right? And in remaining all, you will have ST segment elevation. Then how will you rule out the other options? You take this aortic dissection. In aortic dissection, what is the character of the pain? The character of the pain is tearing type of pain. And this particular pain may radiate to the interscapular regions, right? So the character is very important in aortic dissection. Then musculoskeletal chest pain. So how will you rule out this musculoskeletal chest pain is that, see, this musculoskeletal chest pain, you don't have that particular variation with the posture of the individual. In our patient, the pain is like increasing on lying flat and the pain is relieved in sitting forward. That particular pattern is not seen in case of musculoskeletal chest pain. So in that way, your B is ruled out. Then what about the pulmonary embolism? In pulmonary embolism, what will be the ECG finding? Chest pain, can it be there in pulmonary embolism? Yes. If there is small pulmonary embolism, you can have chest pain. But what will be the very important ECG finding in patients with pulmonary embolism is that they will have sinus tachycardia. This is the most common ECG finding. And you will have the features of right heart strain pattern. So what do you mean by right heart strain pattern? That is right bundle branch block. You will have right ventricular hypertrophy. You will have asymmetrical T-wave inversion from V1 to V3. And in some patients, that is 7 to 10% of individuals, you have S1, Q3 and as well as T3 pattern as well. So that is what you will see in case of the pulmonary embolism. Okay, right. So the answer here is the pericarditis. Yeah, Varun Kashyap, if you take this COVID-19 can cause everything, right? So like COVID-19, it is the one which can cause the multi-system disorder. It can cause endocardial involvement, it can cause myocardial involvement, and it can also cause the pericardial involvement as well. Okay, right. Then what exactly? Yes, Asadullah, what is this particular spodic sign? Okay, so a very good question by Asadullah, that is the spodic sign. So spodic sign in case of pericarditis, it is actually an ECG finding, right? What is this? It is an ECG finding. What should be that ECG finding is like there should be downsloping TP segment. Right, downsloping TP segment, and this particular downsloping TP segment is called as the spodic sign, and it is seen in stage 1 pericarditis. Right, it is seen in stage 1 pericarditis. Okay, yes, Asadullah, is this clear for you? Right, now having said about this particular spodic sign, now we'll move on to the next question. So this question was related to pericarditis. Then okay, now you see which one of the following does not score points on routinely used early warning systems in the context of medical observation monitoring? Read the question properly. Which one of the following does not score points on routinely used early warning systems in the context of medical observation monitoring? Capillary blood glucose, Glasgow Coma Scale scoring, heart rate, SpO2, temperature. Right, very good, Zahid Ansari. So the correct answer here is the capillary blood glucose. Capillary blood glucose is not the one which is routinely used as an early warning systems, whereas you take respiratory rate, saturation, temperature, blood pressure, heart rate, Glasgow Coma Scale, that is neurological response, then urine output. All these are the core components, right? Please remember, these are all the core components in the early warning systems, right? Whereas you take this capillary blood glucose may be used as a part of such a scoring system in specialist department. Like where do we use this? Right, where do we use this capillary blood glucose? We use this in the endocrinology department, but not in case of the early warning systems in ICU. Please remember, this is a very, very important point, right? The question looks simple, but the answer is not very easy. Okay, now you see the next question. In the general medicine setting, this is another very important point. Okay, it is like a type of question which is continuation of the previous question. In the general medical setting, what is the earliest and most sensitive sign of clinical deterioration? Blood pressure, core temperature, heart rate, respiratory rate, urine output. Which one of the following is the earliest and most sensitive sign of the clinical deterioration? Right, very good, Dark Knight. Yes, all of you are answering it correctly. So whoever has answered D, that is respiratory rate. So please remember, a raised respiratory rate, that is tachypnea, is the earliest and most sensitive sign of the clinical deterioration. Right, most sensitive sign of the clinical deterioration. Okay, tachypnea, it may be primary, that is the problem within the respiratory system, or secondary to pathology elsewhere in the body, that is the earliest and most sensitive sign of the clinical deterioration. And all other parameters, they are also the part of the warning systems, but they occur, they tend to be not the first line. Right, whenever the end organ damage occurs, then the other parameters are also taken into the warning systems. But what is the earliest? That is the respiratory rate. Please remember. So if anyone is like worsening, the first important thing like what you need to look for is the respiratory rate. Okay, right. So having said this, yes, in the context of cardiac physiology, which of the following is stroke volume most dependent on cardiac filling? Actually, it's a physiology question, right? Anyways, quickly answer this. Most dependent on cardiac filling and contractility, cardiac index, hemoglobin and oxygen saturation, heart rate and diastolic blood pressure, jugular venous pulse alone. Right. So the correct answer here is the cardiac filling and the cardiac contractility. Now let me just give you the explanation. Now what exactly is the stroke volume, right? So like heart rate into stroke volume will be your cardiac output. Stroke volume is nothing but the amount of blood which is ejected from the left ventricle in a single beat. Okay, the amount of blood which is ejected from the left ventricle in a single beat, that is what is called as the stroke volume, right? And the stroke volume is dependent on the cardiac filling, that is called preload, and the contractility. That means what? More is your preload, more will be your contractility, more will be your stroke volume. Okay, next, what about the cardiac index? So cardiac index is what? Cardiac index is a measure that relates, right, that relates cardiac output multiplied by heart rate to that of body surface area. Okay, so it is not only exclusively for your stroke volume, it takes many parameters into consideration. Hemoglobin and oxygen dissociation curve, this hemoglobin and oxygen dissociation curve or oxygen saturation do not directly affect the stroke volume. Only in extremely very severe situations like extreme anemia or cellular hypoxia, your hemoglobin and oxygen saturation do not directly affect the stroke volume. Only in case of severe hypoxia and as well as the extreme anemia, only in these two conditions the hemoglobin and as well as the oxygen saturation can affect the stroke volume. Then what about the heart rate and diastolic blood pressure? Okay, let me tell you, heart rate, it has some effect on the stroke volume. Definitely it has some effect on the stroke volume. Why? Because the heart rate will decide the time for ventricular filling. Whenever the heart rate is increased, the ventricular filling will be reduced. When ventricular filling is reduced, definitely there will be decreased stroke volume. But however, this heart rate, it is not the main factor. What is the main factor which will decide the stroke volume is cardiac filling and as well as the contractility. Okay, so that is about the stroke volume. Even though this is a question of physiology, always your physiology and as well as medicine, they are integrated. Okay, now this is a clinical question from the medicine. An 84-year-old man is brought to the hospital after a fall. He was found by his daughter and has been lying on the floor for previous 24 hours. He has a variety of soft tissue injuries, but no serious head or orthopedic injuries. On catheterization, his urine is dark brown. Which one of these tests is most suggestive of rhabdomyolysis? Yes, right, very good. So the correct answer here is the creatinine kinase. A creatinine kinase, how much it should be? A greater than 1000 units per liter, right? It is highly suggestive, although it can rise to tens of thousands in severe cases. In severe cases, it can go even up to 10,000 also. But if it is more than 1000, it is highly suggestive of rhabdomyolysis. And if you take the other test, 1 plus blood on urine dipstick, hemoglobin, renal ultrasound, urea, that would not help in the specific diagnosis of rhabdomyolysis. So that is the reason why all other options are ruled out. The correct answer is the creatinine kinase, which is very much helpful for diagnosis of rhabdomyolysis. Okay, this is another very important question related to the emergency medicine. The third international consensus definition for sepsis and septic shock gives a clear definition of sepsis as patients with suspected infection who have two or more of three particular features, right? Two or more of three particular features. Which of these features form the part of the definition? Which of the following forms the part of the definition? GCS less than 15, increase of 1 point on SOFA score, respiratory rate more than 20, serum lactate more than 13.5 milligrams per deciliter, systolic blood pressure less than 110 millimeters of mercury. Okay, so the correct statement here is, okay, so whoever has answered A is correct. Now let me tell you, like, what are all those three? Like, three particular features should be there. Out of these three particular features, at least two should be there to consider that the patient is in sepsis or the septic shock. What are those? See, blood pressure less than 110 is incorrect. It should be less than 100. Okay, that is 1 point. Second, GCS, how much it should be? It should be less than or equal to 14. Less than 15 means what? It can be 14 also. So that is a correct statement to tell that the patient is having sepsis. Okay. And what is the third parameter? The third parameter, respiratory rate, it is not more than 20. Respiratory rate more than 22 per minute. So please remember, hypotension, that is systolic blood pressure less than 100, GCS score less than or equal to 14, respiratory rate more than 22 breaths per minute. If these three are there, or any two out of three, if they are present, that tells the individual is having sepsis. Okay, that tells the individual is having sepsis, right? So the correct answer here is first option, A. And your SOFA score, no, and serum lactate, no. Okay, now what exactly is this particular SOFA score? Let me tell you. So SOFA score, recently they have asked the question on the SOFA score, right? All of the following are included in SOFA score except respiratory rate more than 22, altered mentation, systolic blood pressure less than 100, lactic acidosis. Lactic acid. What exactly is your SOFA score? SOFA score is nothing but sequential organ failure assessment score. Right? What is your SOFA score? Sequential organ failure assessment score. Okay. Very good. So, which is not included in your SOFA score is your D. Your D. That means your lactic acidosis is not the part of your SOFA score. The remaining, if you take the systolic blood pressure less than 100, give a score of 1 point. Then respiratory rate more than 22, give a score of 1 point. Then altered mentation, then if it is there, give a score of 1 point. So if the patient is having higher the score, higher is the chance of the organ failure. Okay, higher is the chance of your organ failure. Okay, so that is about your right. Now, yes, Varun Kashyap, the GCSP, P is nothing but pupil. P is nothing but pupil. Okay, right. Then this is about your SOFA scoring system. Next, now regarding this lactic acid, let me just ask you one question in the emergency care. hyperlactemia is very rarely seen in which of the following situation? Cardiogenic shock, chronic renal failure, major hemorrhage, metformin overdose, sepsis. Any one of you? Right. So, yeah, very good, Khan. So Khan has answered this. Kaunsar Khan and Atul Azad, very good. Whoever is answering B, it's a correct statement. Now, in case of chronic renal failure, the hyperlactemia is very rarely seen. But in all other conditions, you see that particular hyperlactemia. You take all other options. All other options like your cardiogenic shock, major hemorrhage, sepsis, metformin overdose are likely to result in the tissue hypoperfusion. Right? All of these will cause tissue hypoperfusion or poor oxygen utilization. Right? Tissue hypoperfusion or poor oxygen utilization. So whenever there is tissue hypoperfusion or poor oxygen utilization, this will lead to the anaerobic metabolism. Once there is anaerobic metabolism, there is lactic acid which is being accumulated. Okay, right. And metformin, one of the very important adverse effect is the lactic acidosis. Whereas you take in case of the chronic renal failure, there is no particular reason why there should be hyperlactemia in patients with the chronic renal failure. So here answer is the chronic renal failure, hyperlactemia is very rarely seen. Okay, right. Next. A 49-year-old woman is admitted to the acute medical ward with a severe leg cellulitis. Right, with severe leg cellulitis. She has type 2 diabetes with BMI of 41 kg per meter square. That means obese individual. Observation shows heart rate of 119 beats per minute, respiratory rate 20 breaths per minute, the blood pressure 70 by 35, saturation 97% on room air, temperature is 38 degrees centigrade, GCS 15. Which one of the following treatment would you initiate first? Crystalloid IV bolus up to 30 ml per kg, right? Hydrocortisone 100 milligrams IV, peripheral IV adrenaline, peripheral IV noradrenaline, vasopressin. Very good. So the correct answer here is the crystalloid IV bolus of up to 30 ml per kg. See, this particular patient is in sepsis. This woman is in sepsis. Okay, so in patients with sepsis, the initial treatment of which include two important things. One, you should give antibiotics. That is one important thing. Second important thing is the supplementation of IV fluids. Okay, so that is the reason why the correct answer here is the crystalloid IV bolus of up to 30 ml per kg. Now, what about the other options? The other options may all be used to manage the sepsis, right? You take adrenaline, noradrenaline. When do we give this adrenaline, noradrenaline or vasopressin? We give when the patient does not respond to your IV fluids. Then we give this particular vasopressors, okay? And you take this hydrocortisone. When will you give this particular hydrocortisone? If the patient is having the addisons, right, adrenocortical insufficiency, or in case of myxedema coma, then we give this particular hydrocortisone. Okay, so the woman has sepsis, the initial treatment of which includes the early antibiotic and as well as IV fluids. So that is the reason why the correct answer is the crystalloids that you need to give. Along with that, you also need to give antibiotics. Okay, right. Okay, for which of these conditions is non-invasive ventilation the first line respiratory treatment? Epiglottitis, H1N1 influenza, mild congestive cardiac failure, severe pneumonia, type 2 respiratory failure with respiratory acidosis. Mild congestive heart failure. See, if it is mild congestive heart failure, what we give is the furosemide, and we don't put the patient on the BiPAP. We just connect the patient to the oxygen mask. So here the correct statement is the type 2 respiratory failure. Okay, so non-invasive ventilator, that is in the form of bilevel positive airway pressure, right? So In case of type 2 respiratory failure, that should be the first line management. First line management in case of your respiratory failure, particularly type 2, will be your NIV, and that too in the form of BiPAP. And in case of type 2 respiratory failure, what are the parameters that you will see? There will be hypoxia and there will be hypercapnia. That is what you will observe in case of type 2 respiratory failure. Next. Now, yeah. Yes, Khan. In case of cardiogenic shock also, yes, we put on BiPAP or your non-invasive ventilator. But if you take the third option, it is mild congestive heart failure. I did not tell you that there is a cardiogenic shock, right? So the answer here is E. Okay. The following are all terms that are used in relation to complications of invasive ventilation for patients in an intensive care setting, except for one. Which is the one that is not a real term used in this context? Atelectotrauma, barotrauma, biotrauma, pulmotrauma, volutrauma. You will understand the question first. Not a real term. Biotrauma we use. Yes, many people, many of you did not listen biotrauma, but we use the term biotrauma. So, which is that particular term which is not being used is your pulmotrauma, right? Pulmotrauma is not being used. What about the other options? I'll tell you. You take this volutrauma, right? So volutrauma is the result of distending forces from the tidal volume. Okay, volutrauma is the result of distending forces from the tidal volume. That is what is your volutrauma. Then you take this barotrauma. Barotrauma, it results from excessive pressures required to inflate the lung. Right? Whenever we are using the excessive pressures to inflate the lung, there can be barotrauma. What about atelectotrauma? Atelectotrauma results from the alveolar collapse. Can result from alveolar collapse. Okay. So results from alveolar collapse and reopening throughout the respiratory cycle. What about this biotrauma? See, there will be release of the cytokines, right? There will be release of the cytokines. So release of the inflammatory cytokines in response to cyclical distension is termed the biotrauma. So biotrauma also there is a terminology, and that is due to release of inflammatory cytokines in response to cyclical distension. But pulmotrauma is not used in invasive ventilation nomenclature currently. So the correct answer here is D. Right. Yeah, Gokul Krishnan, you're asking about types of respiratory failure. Okay. So let me just quickly recap types of respiratory failure. Type 1, type 2, type 3, and as well as type 4 respiratory failure. So your type 1 respiratory failure, it is due to alveolar flooding. And where can you have this particular alveolar flooding? You can have that in pneumonia. You can have that in patients with ARDS also. And this particular patients, all of them, they have to be managed on ventilator. So in all these patients, you have to start with NIV only, non-invasive ventilator. And what will be the parameters? There will be hypoxia and carbon dioxide levels, they may be reduced or carbon dioxide levels may be normal in type 1 respiratory failure. And what about type 2 respiratory failure? As I have said you, hypoxia will be there and hypercapnia will be there. And this is due to alveolar hypoventilation. And this alveolar hypoventilation could be due to many reasons. That is brainstem lesion or myoneural junction dysfunction like myasthenia gravis Guillain-Barré syndrome. That is your type 2 respiratory failure. They also have to be started with non-invasive ventilator. Type 3 respiratory failure, they are nothing but your perioperative respiratory failure. That means immediately after the surgery, the individual is not recovering immediately from that anesthetic agent, or the individual is not recovering from that skeletal muscle relaxant effect, which is usually being given during surgery. And because of that, the diaphragmatic muscles and respiratory muscles have not regained their function. So the individual will be in a state of respiratory failure. That is type 3 respiratory failure. And type 4 respiratory failure, that is due to cardiogenic shock, right? That is due to cardiogenic shock. Okay. And once there is cardiogenic shock, respiratory muscle perfusion will be reduced, resulting in type 4 respiratory failure. Okay. Yes, who has asked me this? Gokul Krishnan. Yes, Gokul Krishnan, is that clear for you? All the types. And in all of these respiratory failure, the first line management will be NIV, non-invasive ventilator. And if the patient does not respond with non-invasive ventilator, then we put the patient on mechanical ventilator with endotracheal intubation. Okay, right. So having said this, we move on to the next question. Just 1 minute. Right. Yes, Asadullah. Is GBS type 2? Yes. Yes, Asadullah. Guillain-Barré syndrome, it comes under type 2 respiratory failure. Type 2 respiratory failure. Okay. Right. And Gokul Krishnan, you take your COPD story. In COPD, emphysema will be your type, sorry, emphysema will be type 1 respiratory failure. Chronic bronchitis will be type 2 respiratory failure. Okay. And what about myopathy? Myopathy and as well as neuropathy. Even these, they will lead to type 2 respiratory failure only. Okay, Gokul Krishnan, is that clear for you? In COPD, you have mixed emphysema type 1, chronic bronchitis type 2. Okay. Now we'll move on to the next one. And what about pulmotrauma? Yes, Jahid Ansari, we don't have a terminology called pulmotrauma. We don't have the terminology called pulmotrauma at all. Okay, we have barotrauma, we have atelective trauma, you have like biotrauma and all, but we don't have the pulmotrauma. Okay. Now the next question is, using checklist for interventions in ICU is a key component of a good patient care. Which of the following forms part of the fast hug checklist? Right, very good, Dark Knight and as well as Khan, Kaunsar Khan. The answer is the yes, ulcer prophylaxis. Now in this particular fast hug, like what are all the abbreviation of this particular fast hug? So that means in a very good patient care, what does this fast hug stands for? The word F stands for feeding. The word F stands for feeding. The word A stands for analgesia in the fast hug. And what about S stands for? That is sedation. And what about T stands for? That is thromboprophylaxis. Right? That is thromboprophylaxis. That means DVT stockings or the low molecular weight heparin should be given. And the word H stands for the head end elevation. Right, head end elevation, that is mainly to reduce the incidence of passive aspiration, so head end should be elevated. And U stands for the ulcer prophylaxis. And what does this G stands for? G stands for glucose control. So these are the components of your fast hug, right? And it is not your foot care, it is not gowning and glowing, it is not spinal problem, it is not teeth. Okay. Yes, what about asthma? Yes, Gokul Krishnan, very good question. And even you take bronchial asthma, like bronchial asthma, depending upon your FEV1, right? We classify bronchial asthma into mild, moderate, severe, and as well as very severe. Mild, moderate, severe, and very severe. So your bronchial asthma is type 1 respiratory failure if it is mild and moderate. And whereas your bronchial asthma will be type 2 respiratory failure if it is very severe bronchial asthma. Like for example, you take status asthmaticus. Status asthmaticus will be your type 2 respiratory failure. Whereas mild form of asthma, that will be type 1 respiratory failure. Okay. Right. Yes, Gokul Krishnan, I hope the point is clear for you. Okay. Now we'll move on to the next question now. So these are some of the questions. These are some of the questions on the topic of the emergency medicine, right? So definitely I do understand that some of you are answering correct and some of you are answering incorrect. And definitely that particular state of disappointment comes whenever you are answering incorrectly. So whenever you are disappointed when you are giving grand test, or whenever you are answering incorrectly, whenever you feel disappointed, please remember one important point. An individual or any person's best success comes after their greatest disappointments. Only after many disappointments, the best success will come. So if you're answering incorrectly, please don't feel disappointed. Okay. And see, you should be in a state of accepting that short-term disappointment, but never lose that infinite hope. That is very, very important in your preparation. So what you need to know is life is not always a celebration. Okay, so be ready to courageously face the disappointments whenever they come, and be sure to grow stronger and wiser from that particular disappointments. Disappointment, yes, they are unfortunate but somewhat inevitable part of our life. Okay, so please don't feel disappointed if you are answering incorrectly. These are all, the part of you getting into a stage of success, right? So be strong enough and try to answer all the questions. Okay, right. So having said this, we'll move on to the next one. Yes, most women with genital chlamydia trachomatis or symptomless. In women who do develop symptoms, which one of the following is the most common symptom? Deep dyspareunia, dysuria, increased vaginal discharge, lower abdominal pain, unexpected vaginal bleeding. Right. Yes. Any one of you, please. Oh, very good, Asadullah. Yes, better to make mistakes now rather than on examination day. Right. So the correct answer here is, okay, some of you have answered it correctly. That is unexpected vaginal bleeding. Now, this chlamydia, what it will do is, it will cause cervicitis. Okay, chlamydia can cause cervicitis. And because of this cervicitis, there can be friability of the genital tract. So because of cervicitis, that will result in friability. And because of this friability, there may be unexpected bleeding. There may be unexpected bleeding. Okay, right. What about your dysuria? When will the individual develop dysuria? Whenever there is development of urethritis, right? Then the individual will develop dysuria, that is burning micturition. With chlamydia, urethritis is less common. So your dysuria is incorrect statement. Okay. Then what about the deep dyspareunia? That is the painful intercourse. Deep dyspareunia and lower abdominal pain are symptoms of ascending infections. That means where can you get this deep dyspareunia? Like whenever the individual develops salpingitis, that is the fallopian tube involvement, or in case of pelvic inflammatory disease, there you get this deep dyspareunia. It is less frequently seen with your chlamydia. So deep dyspareunia ruled out. Then what about the vaginal discharge? Increased vaginal discharge is possible, but in most cases is probably due to an unrelated conditions like bacterial vaginosis or candidiasis. That means along with chlamydia, there would be secondary infections with bacterial vaginosis or candidiasis. Then only there could be an increased vaginal discharge. That is being possible. But only with chlamydia, increased vaginal discharge is not possible. Okay. And even your lower abdominal pain, what did I tell you? It is possible with salpingitis and pelvic inflammatory disease. So the correct answer is the unexpected vaginal bleeding that can be seen associated with chlamydia, because that can cause cervicitis, and the resulting friability may present as unexpected bleeding, especially after the sexual intercourse. Okay, right. So that was one important question related to chlamydia. Right, another STD. A patient with confirmed infection with HSV2 has had symptomatic recurrences approximately every month for past year. What is the standard first line antiviral regime to be prescribed in this case? Acyclovir 200 milligrams 4 times daily, acyclovir 400 milligrams twice daily, famciclovir 250 milligrams once daily, famciclovir 750 milligrams once daily, valacyclovir 500 milligrams once daily. Okay, right. So The correct statement here is A. That is acyclovir 400 milligrams twice daily is the correct statement. See, what does the previous studies have shown that is the earlier studies using acyclovir to suppress the recurrences found that 200 milligrams 4 times daily was more effective than compared to that of 400 milligrams twice daily. But that particular difference is very small. But that particular difference is very small enough. Okay, so now whenever you are giving 4 times daily, the frequency with which the individual has to take the medication is more. There is very high chance that the patient can miss the tablet. So that is the reason why instead of 200 milligrams four times daily, 400 milligrams twice daily is considered to be the best for preventing the recurrences with your HSV2. Now, what about this famciclovir and valacyclovir? Valacyclovir and famciclovir are more expensive. So that is the reason why they are reserved for cases where acyclovir is ineffective. And not only that, you take this valacyclovir. The dosage is 500 milligrams once daily, that is correct. But if you take the famciclovir, it is 250 milligrams twice daily. It is not once daily, right? It is not once daily. It is 250 milligrams twice daily. That is what is the dosage of the famciclovir. So what is the correct statement here? That is the acyclovir 400 milligrams twice daily is the correct statement in this question. Okay. Sir, can epinephrine be given during asthmatic attack? Okay, who is this? Keratin pulse, right? So keratin pulse, you take the anaphylactic shock when a patient is in case of the anaphylactic shock, okay, or the patient has developed some severe anaphylaxis secondary to some allergic agent. And you know what is the drug of choice here? And these patients, they can have very severe bronchoconstriction causing dyspnea. And what is the drug of choice here? That is epinephrine. That is epinephrine. Okay. Yes, keratin pulse, we can give epinephrine during the asthmatic attack, but it should be secondary to some anaphylaxis causing severe bronchoconstriction. Okay. Right. Now we'll move on to the next question. Okay, so this question was slightly difficult because the dosages have been asked, and sometimes if your time is bad, you can have the questions related to the dosages also, and you need to be prepared for that. Okay, a 34-year-old human that is HIV positive, right? HIV positive man who has sex with men, that is MSM, complains of severe rectal pain, blood-stained discharge and tenesmus. He is taking antiretroviral therapy and having a CD4 count of 636 and an undetectable HIV viral load. Proctoscopy reveals rectal inflammation and visible mucopus. Which is the most likely cause of this presentation? Campylobacter infection, cytomegalovirus colitis, gonorrhea, lymphogranuloma venerum, secondary syphilis. Right, very good, Anubhav. Only one student has answered correctly until now. Right, so that is the lymphogranuloma venerum. See, lymphogranuloma venerum is the likeliest cause of severe proctitis. Right, it is the likeliest cause of the severe proctitis and is most often diagnosed in HIV positive MSM. Right, MSM is men having sex with men. Then what about this gonococcal proctitis? See, gonococcal proctitis, it is usually less severe than in this particular case, right? And they are very rare in case of the HIV individuals. Okay, then what about this Campylobacter infection? Campylobacter infection is seen in MSM, but what will be the presentation in Campylobacter? That will be in the form of diarrhea, but not in the form of the severe proctitis. Then you take this cytomegalovirus colitis. Cytomegalovirus colitis is seen only in end-stage HIV infection. But if you take the CD4 count of our patient, right? If you take the CD4 count of our patient, the CD4 count is 636, right? It is not end stage HIV infection. So your cytomegalovirus is also ruled out. Okay, so the correct statement here is the lymphogranuloma venerum. Okay, right. Having said this, we'll move on to the next question. Most of the following are complications of disseminated gonococcal infection. Which would you be unlikely to see as a recognized complication of disseminated gonococcal infection? Most of the following are complications of DGI. Which is the complication not seen in DGI? So, if you take the typical manifestations of disseminated gonococcal infection, what would be the typical manifestations? That would be in the form of monoarthropathy, right? That would be in the form of monoarthropathy, that is involvement of the single joint, right? And the other important manifestation is the vasculitic rash, and third important is the tenosynovitis. And these are the earlier, typical manifestations of your DGI. Endocarditis can also be seen, but comparatively rare. But what about uveitis? Uveitis, it is not seen with disseminated gonococcal infection. Then uveitis is seen secondary to which particular sexually transmitted infection? It is seen secondary to syphilis. Right, it is seen secondary to syphilis, but not secondary to disseminated gonococcal infection. So that is the reason why the correct answer here is the uveitis. Then, which of the following antimicrobial drugs is unlikely to be effective against genital chlamydia trachomatis infection? Amoxicillin, ciprofloxacin, erythromycin, ofloxacin, oxytetracycline. See, presently for the chlamydia trachomatis, which is being effectively used is azithromycin is being used, and as well as doxycycline is being used. And before the advent of this azithromycin and doxycycline, what we were using is erythromycin and oxytetracycline were being used as anti-chlamydial agent. Okay. Now, you take the ofloxacin. Ofloxacin being quinolone, it also has an anti-chlamydial efficacy, but ciprofloxacin does not have anti-chlamydial efficacy. What about amoxicillin? Amoxicillin was found to be effective in the treatment of chlamydia in pregnancy. So in pregnancy, if there is chlamydia infection, then amoxicillin can be used as the anti-chlamydial agent. But what we don't use for chlamydia, or which of the following antibiotic does not have anti-chlamydial activity, is the ciprofloxacin. Okay, right. So that was about some questions related to the infectious diseases which have been asked previously. Now let me take up the questions on the cardiology, right? PYQs on cardiology. Okay, right. Association of condition shown in photograph includes all except. So now what exactly is the image shown to you here? That is your coarctation of aorta. Now what is the asked here? That means which of the following is not associated with the coarctation of aorta? Please remember, among your Turner's, Downs, ventricular septal defect and patent ductus arteriosus, you take this Down syndrome. Okay, Down syndrome, there is no association with the coarctation of aorta. Then what about the other options? You take this coarctation of aorta. Coarctation of aorta, it is commonly associated with other cardiac and extracardiac anomalies. This particular coarctation of aorta is associated with bicuspid aortic valve, right? It is associated with the bicuspid aortic valve, and it is also associated with transposition of the great arteries. It is also associated with ventricular septal defect. It is also associated with patent ductus arteriosus, and it is also associated with other syndromes like the Turner syndrome. But in Down syndrome, you don't have this coarctation of aorta. And if you take in Down syndrome, what are the cardiac abnormalities in Down syndrome? The cardiac abnormalities in Down syndrome is atrioventricular septal defect. That is nothing but your endocardial cushion defect. And in Down syndrome, there can be development of VSD. In Down syndrome, there can be development of patent ductus arteriosus. And in Down syndrome, there can be development of tetralogy of Fallot, but not your coarctation of aorta. So the correct answer here is the Down syndrome. So Down syndrome and coarctation of aorta, there is no relation at all. Okay, right. Now we'll move on to the next question. Okay, you see this question. Abdomen must be compressed for how many seconds for reflux to appear, right? What exactly is the reflux that you are seeing here? You are applying the pressure over the abdomen and you are seeing the jugular vein. So it is nothing but your hepatojugular reflex. So for how long you need to compress the abdomen to see the reflex? 1 to 5 seconds, 5 to 10 seconds, 10 to 15 seconds, 1 to 2 minutes. Right, so the correct statement is 10 to 15 seconds. Okay, so like in order to have the hepatojugular reflex, the abdomen has to be compressed for nearly around 10 to 15 seconds. Now, if the hepatojugular reflex, if it is like more than 3 centimeters, and if it is sustained even after removal of the pressure from the abdomen, then we consider it as a positive hepatojugular reflex. Now, if suppose after removal of the pressure from the abdomen, if the hepatojugular reflex will return back to normal, then we consider it as negative hepatojugular reflex. Okay, so please remember these two important points, positive and negative. Positive means the hepatojugular reflex will increase more than 3 centimeters even after removal of the pressure from the abdomen. Negative means the hepatojugular reflex will return back to normal after removal of the pressure from the abdomen. Okay, right. Now, in which all conditions you will have the hepatojugular reflex positive? Like in patients with right heart failure, constrictive pericarditis, right ventricular infarction, restrictive cardiomyopathy. In all these conditions, the abdominojugular reflex will be positive. Okay, right. Then you see the next question. Severe stenosis, right? Severe stenosis of the valve shown in photograph correlates with loud opening snap, loud S1, duration of mid-diastolic murmur, intensity of the mid-diastolic murmur. Okay, so what is being mentioned here is, right, so what is being mentioned here is, it is the mitral stenosis. The mitral valve is being shown to you with the arrow, and the question asks the severe stenosis of the valve shown in. Now, in case of mitral stenosis, how can you assess the severity based on examination is, one is the duration of mid-diastolic murmur. More is the duration of your mid-diastolic murmur, like more severe is your mitral stenosis. And second important point is the A to OS gap, right? A to OS gap, right? So these two parameters, duration of mid-diastolic murmur and A to OS gap, these two will decide the severity of mitral stenosis. So the correct answer here will be C. Next. Right. Diagnose the underlying medical disorder by ECG change in the photograph. Hyponatremia, hyperkalemia, hypercalcemia, hypocalcemia. Diagnose the underlying medical disorder by ECG change in the photograph. So, if you observe very clearly there, what is being given to you is a long QT interval. Okay, if you calculate the QT interval, if it is more than 440 milliseconds. Now, whenever there is a long QT interval, what all you need to suspect? You need to suspect hypocalcemia, you need to suspect hypokalemia, you need to suspect hypomagnesemia. So the correct statement here will be the hypocalcemia. The correct statement here will be the hypocalcemia. Okay, right. Then you take the other questions. Just a minute. That is the questions related to the arterial pulse. The questions related to the arterial pulse, right? See, this is the normal arterial pulse, right, where you have a percussion wave and as well as the dichrotic notch. Now tell me, where, in which conditions you get this, the pulsus paradoxus, and this will be the last thing in the discussion. So what are the conditions where you will have this pulsus paradoxus? Right. So pulsus paradoxus, you get this in patients with the cardiac tamponade. You get this rarely in patients with the constrictive pericarditis. Right. And the other conditions where you can have this pulsus paradoxus is in patients with status asthmaticus. And you come across this in patients with severe COPD. And you come across this in patients with, what are the other conditions where you can have this? You can also have this in patients with morbid obesity. Okay, so these are all the, and even in pregnancy, these are all the conditions where you can have the pulsus paradoxus. Okay, right. This is an image based question. Now tell me, where do you get this particular characteristic pulse? I'll just show you all the various characters of the pulse and then we will wind up this session. That is called pulsus bispheriens. Pulsus bispheriens is what? You have the presence of two peaks in systole. Right? Presence of two peaks in systole is what is called the pulsus bispheriens. Now, which all conditions you can come across this pulsus bispheriens is in patients with hypertrophic obstructive cardiomyopathy, in patients with AS with AR, and in patients with severe AR. So these are all the conditions where you can have the pulsus bispheriens. Okay, right, where you have the presence of two peaks in the systole. Then the other characteristic image can be about dichrotic pulse. Now, what do you understand by this word dichrotic pulse? Dichrotic pulse means you have one peak in systole and the second peak, okay, and you have another one more peak in diastole. Okay, that is called dichrotic pulse. Now, which condition you will have this dichrotic pulse? Dichrotic pulse, please remember, you come across this in patients with dilated cardiomyopathy. You come across this in patients with the dilated cardiomyopathy, you will have dichrotic pulse. Okay, right. Then coming to pulsus alternans. What is pulsus alternans? One, you have a normal or strong pulse. The other, you have a weak pulse, right? Strong and as well as the weak pulse. Where do you get this pulsus alternans? You get this in patients with severe left ventricular failure. At this point, you should also know a terminology called electrical alternance. Electrical alternance is what? It is an ECG finding. Electrical alternance is an ECG finding. Electrical alternance, you get this in case of massive pericardial effusion. You get this in massive pericardial effusion. There you get this pulsus alternance in severe left ventricular failure. Electrical alternance in massive pericardial effusion. Okay, right. Next, one more characteristic pulse is the pulsus bigeminus. Pulsus bigeminus, how is it different from pulsus alternans? You will have a normal pulse, then you will have a weak pulse, then you will have a compensatory pause. Then you will have a compensatory pause. Then you will have a normal pulse and then the weak pulse. So yes, you get this in case of digoxin toxicity. Digoxin toxicity. Okay, right. And the last slide for the discussion is about the water hammer pulse. Now the position is very, very important. See, the patient has to examine the water hammer pulse in this position. And where do you come across this water hammer pulse? You come across this in aortic regurgitation. You come across this in patients with severe mitral regurgitation, right? And all of your hyperkinetic states, you get this water hammer pulse. Okay, so with this I'm done with this particular session. Okay, so the PDF of this particular session will be sent onto my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can just join my Telegram channel and you can get this particular PDF for you, right? And tomorrow again we have another session of the PYQs only, right? Tomorrow session will be at 6 p.m. So meanwhile, on my Telegram channel, you can text me your doubts or text me your queries, and any particular topic you want me to discuss, I will discuss. Okay. So you just text me on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Definitely I'll discuss that particular topic, whatever you want. Okay. With this, I wind up this particular session of PYQ. Tomorrow 6 p.m. again I'll come live to discuss few more PYQs in the general medicine. Thank you very much and see you tomorrow again.